and welcome to our webinar on veterinary point of care pleural space and lung ultrasound for everyday practice. I'm Jeunesse Castalgay, VP at Clarius. I'd like to start by acknowledging the wonderful folks at the Vet Show and NAVC, the North American veterinary community, for inviting so many of you to join us here today. Over 3,100 doctors of veterinary medicine registered for today's educational event. Good morning, afternoon, or evening, depending on where in the world you call home. Dr. Soren Boysen and Dr. Serge Chalhoub have prepared a dynamic and very comprehensive presentation for us today. You may ask questions anytime during the webinar using the question box, but today our live Q&A session will begin at the end of the hour. We hope you can stay on with us for the 15-minute live Q&A with our doctors. Now, without further ado, let me introduce you to your host. Trained in emergency medicine in California, Dr. Eran Frankel is a passionate POCUS educator. He currently practices in a busy academic teaching hospital in Vancouver as an emergency physician and also serves as the chairman of our Clarius Medical Advisory Board. Hi, Dr. Frankel, over to you.
Hi, Jeunesse, thanks. I want to get to the meat of the presentation, and it's great to be here. I'm not a veterinarian, it's true, but we do share a common goal of rapid, effective diagnosis. And when I see patients who present with dyspnea, I know that the chest, I approach it like a black box. There's a lot of things going on in there, and I'm not really sure sometimes how to quickly ascertain an effective diagnosis to implement a treatment plan. But the differential diagnosis when I see patients with dyspnea is quite long, and narrowing it down can be really challenging because it crosses so many organ systems. And what we've seen in the human space is that, with point of care ultrasound, more and more evidence is accumulating that ultrasound may be actually our best standard of care, particularly for going up against a stethoscope in diagnosing pulmonary conditions. We haven't had a technology change the way we relate to patients in over 200 years when the stethoscope was invented. And so it's no surprise that the ultrasound is far superior to our physical exam skills with regards, especially to sensitivity and specificity with a lot of pulmonary conditions. What is surprising though, is that lung ultrasound really far outshines X-ray performance in a lot of pulmonary diagnoses, to the point that for many pulmonary conditions, point of care ultrasound performs almost as good as CT scans. And while the studies may not exist in the vet world yet, the fundamental physics are essentially the same. And so there's no reason to think that it's going to be any different. And I don't know how many of you participating in the webinar have CT in-house, but here is a technology that can transform how we're approaching dyspneic patients and giving us profound diagnostic power in our hands. And to better introduce this topic and bring us up to speed in the veterinary world, I couldn't think of better expert guest speakers to join us today than Dr. Soren Boysen and Dr. Serge Chalhoub. It's our honor to introduce them from the University of Calgary Faculty of Veterinary Medicine. Dr. Boysen is a specialist in veterinary emergency and critical care, while Dr. Chalhoub is a specialist of veterinary internal medicine, small animals. They're both recipients of numerous teaching and speaking awards and considered pioneers of veterinary POCUS, having introduced the veterinary profession to the FAST exam through the original study published in 2004, and having a combined total of over 25 peer-reviewed articles and book chapters on the subject. Doctors Boysen and Chalhoub, over to you guys.
Hello, everyone, and thank you for joining us. And I am Serge.
And I am Soren, and we're coming to you virtually from the beautiful Rockies, as you can see here in Calgary, Alberta. And today we're going to talk to you guys about point of care ultrasound.
Yeah, we're very, very excited to be here. And again, thank you so much for having us. We're excited to share with you what we know on point of care ultrasound. Dr. Boysen, first of all, let's just, in relation to this presentation, we received conference honorariums, but otherwise declare no conference of interest. Dr. Boysen, are we going to talk about everything point of care ultrasound today?
So point of care ultrasound involves many different views and assessments, Dr. Chalhoub. Unfortunately, we can't cover it all as much as we'd like to. We're going to focus ourselves today on pleural space and lung, and we're only going to be able to cover a small part of that, unfortunately. But we are going to go through some of that. We're going to give you guys a good feel for why it is we're using point of care ultrasound. And as you can see in this image here, this is you, Dr. Chalhoub, with your mask on. It's a current image. You can see how easy it is for us to gain information right there at the cage side, or even with an owner. If we had to do that, we could have the owner there. We can show them with the iPad or an iPhone and the Clarius, and we'll go through that in today's talk, how we can integrate point of care ultrasound into our daily practices. We don't have to be specialists to do this, and we're doing this on a regular basis.
Well, Dr. Boysen, I have to give you a personal disclosure. I see an animal in respiratory distress, and I just want to run as far away. That's maybe the internist in me, but These patients, very stressful.
All right, Dr. Chalhoub, and that is why you're in internal medicine and I'm in emergency critical care. I see these patients. I find these a good, interesting challenge. These are exciting, but it is true they can be stressful, especially if we're not dealing with them on a regular basis and don't have all of that equipment at our fingertips.
Right.
So we have to stabilize these patients with minimal stress. Don't increase their work of breathing. Don't decompensate them. But the thing on this is, we don't have the ability to do everything we want to do. We can't actually stress these patients, and that limits what we're going to be able to do when it comes to assessment and evaluation, Dr. Chalhoub.
100%. And as good clinicians, Dr. Boysen, we have to start with the history and physical exam findings. I mean, that's just natural. That can really help us get ahead here.
So that puts us in the right direction, Dr. Chalhoub. There's no doubt history and physical examination are important. This, unfortunately, is a kitty cat that had a collar placed when it was a kitten, never was replaced, never had it enlarged. This cat grew into that collar and unfortunately developed respiratory problems because that collar became very, very tight. And you can probably guess, and we'll come back to that, on what this cat's underlying problem was. This puppy dog over here that you saw in respiratory distress, he came in with a history of rodenticide ingestion. So this guy came in with, again, what we suspect when they're respiratory distressed, what the underlying cause is. So we have a feel for that, Dr. Chalhoub. So can you tell me with certainty, though, that what the underlying problem in this kitten is?
Well, I probably can because I'm an internal medicine specialist and I have much more knowledge than you. But the reality is, I really like that analogy of the black box, right? They're big mysteries. So we need some diagnostics here, Dr. Boysen. And again, radiographs are something we're all trained upon and probably all comfortable doing at some point, and that's certainly something we could do.
Absolutely. This cat came in, it's an upper airway obstruction. It's going to be a non-cardiogenic pulmonary edema that we can see. We had a suspicion of that on the history. We had to get confirmatory diagnostics. In this case, it was radiographs. Same thing with the dog that came in rodenticide and we got respiratory distress. He's got pleural effusion because of hemothorax, Dr. Chalhoub. So there's no doubt X-rays are extremely valuable, Dr. Chalhoub.
Right. Absolutely, Dr. Boysen, but I think there's times where radiographs are potentially dangerous to take if that patient is extremely dyspneic and we have to move it to another room, or whatever respiratory disease is going on is so severe that they start looking like a turkey on X-rays.
Absolutely, Dr. Chalhoub. These X-rays should never have been taken. How you end up, this is actually the lung. Look how squished it is. This is a tension pneumothorax. Unfortunately, this patient did not leave the hospital. This is an X-ray that unfortunately should never have been taken, Dr. Chalhoub. And I would say that I think all of us have either been in this situation or know of a situation where a patient, because of the restraint required in our veterinary patients to get those radiographs, causes an increased work of breathing, causes stress, and they actually arrest because of our efforts to try and figure out what's going on. We need to stop doing that, Dr. Chalhoub.
100%, Dr. Boysen. I agree with you 100%. And this is the beauty of point of care ultrasound. It is patient side, minimally invasive. We can stabilize the patient at the same time. We don't have to stress it out. And we get answers live in real time right there. There are so many applications, Dr. Boysen. I love your saying about this.
Yeah, absolutely, Dr. Chalhoub. And if you can put a stethoscope on it, if you can listen, you can look, Dr. Chalhoub. And you can see there's no more stress in holding a stethoscope, or in this case, there's probably even less. You're actually reaching in. They've got the oxygen on this cat here because it came in for respiratory distress. You can see that. We're reaching in. There's no cords in the way. There's no length of stethoscope. You're not restrained by having to have your head in close by the length of that stethoscope. You're actually reaching in. You've got your phone or your iPad in your other hand. No interruption, stabilization. So this is a really nice application of that point of care ultrasound that we can do in the clinic setting now.
And you know what the best part is? It's live, real time, and I'm going to make those interpretations. And as you will see, it is something that is applicable to everyone, that everyone can learn. I think it's important to do a case, Dr. Boysen. Let's talk about Kira. She was hit by a car. He was hit by a car. My apologies. Castrated dog, came in quite unstable and dyspneic to kypnic.
Yeah, we had decreased breath sounds on the right side, some crackles on the left. So again, our history and his physical examination is going to give us a bit of a feel for what might be going on. You can see the minimum emergency database here, Dr. Chalhoub. Simply going to confirm that we do have probably some hypoperfusion or stress going on. Our lactate's up at 3.5, a little bit elevated. And we have a slightly decreased SpO2, again, confirming that we probably have some problem at the lung level with that gas exchange, Dr. Chalhoub. So as an internist, I'm going to ask you these questions. I think you can probably get this, even though this is a trauma case and it's more emergency critical care. What do you think, based on these presenting signs, Dr. Chalhoub, your big differentials in this particular patient is?
I'm already about 6 blocks away seeing all that blood, Dr. Boysen. So no, in all honesty, I'm worried about pulmonary contusions here, Dr. Boysen.
All right, so that is definitely a differential, Dr. Chalhoub. One of the other ones we would have would be pneumothorax.
Pneumothorax, big one.
And then we might have hemothorax.
Hemothorax.
Not as common in our veterinary patients because they usually, unfortunately, if they have significant hemothorax, they won't make it to the hospital, unlike our human counterparts where they get a greater degree of on-site stabilization.
Yep.
Our veterinary patients, unfortunately, they don't often make it, but hemothorax is on the list along with diaphragmatic hernia. Yeah,
100%. So those are the top things we think about, those clinical drawers that open. And the cool thing is, Dr. Boysen, point of care ultrasound, we can look at this. Now let's talk specifically today about pleura and lung ultrasound plus point of care ultrasound. There are 4 key pathologies, Dr. Boysen, that we can evaluate with plus ultrasound. What are they?
Yeah, and a lot of research done on this on the veterinary side. This is where most of it focuses to. And those things are going to be pneumothorax, Dr. Chalhoub. So we're going to start with the pleural space because there's the pleural space and then there's lung. Let's start with pleural space. One of the big ones we look for in our veterinary patients, pneumothorax. For sure. And definitely a possibility in cura.
Absolutely. And then we're going to talk about pleural effusion, another big one, not just for those hit by cars, but a lot of those cats coming in, they're coming dyspneic to tachypneic. Pleural effusion is a big one on that list.
Absolutely. So that's a good differential for a lot of different underlying problems in our patients. And then we're going to talk about things that often will come in not only with respiratory distress, but for coughing, Dr. Chalhoub. And that's going to be lung parenchyma. So we can actually look at, despite the fact nobody believed this was possible 20 years ago, you can look at lung, not necessarily the tissue of the lung, but you can look at and figure out what's going on in the lung based on lung ultrasound. So we're going to look at and discuss wet lung. And although we won't have time to do it today, we also have the possibility to look at consolidations. So these are the 4 big things, 2 big spaces, pleural space and lung. And we look at these 4 big pathologies, but we're not going to cover all those today. We're going to cover some of them, and we're going to do that with cura. So let's come back to cura here, Dr. Chalhoub. What was one of your big differentials that you were looking for?
Well, it was definitely pneumothorax, hit by car dog, very common possibility to see, Dr. Boysen. So it is important for us to look at that. And the thing is, we are looking for air here, right? Between the 2 pleura, we're looking for air. We got to think about this patient, what patient position. Whoa, I'm like getting all flustered here, Dr. Boysen. Where do I start putting my probe here?
So you did the right thing, Dr. Chalhoub. As an internist, you did the right thing. You assessed the information. You asked the clinically relevant question, and that was, in this patient, do I have pneumothorax?
Okay.
So you're looking for what type of pathology? Air in the pleural space. So now we need to consider patient position and where that pathology will accumulate.
All
right. And you can see in a standing patient over here, we've drawn an arrow. That air is going to rise to the most non-gravity dependent region. That's going to rise to the caudal-dorsal site. A little bit different, like you see here in this patient that's being scanned in a little bit of a semi-recumbent position. That air is going to again rise to the most non-gravity dependent area, and that's the site we want to focus or scan on. You can see that. You can bring this probe to the patient in a cage. You've got the phone here, and again, they're looking for that pneumothorax there in this case.
So what I'm hearing from you, Dr. Boysen, first, I asked that clinically relevant binary question: is there pneumothorax in this patient? Number 2, I think about patient position, and then number 3, I got to get my probe to the most sensitive spot, thinking about patient position and how that pathology is going to end up there.
All right. And my question to you, Dr. Chalhoub, this is a patient that comes in with respiratory distress. It's having trouble breathing. What position do you want to scan it in, Dr. Chalhoub?
Sternal or standing for sure, because it's going to be easier to breathe, easier for me to give interventions as well, give oxygen, get ready to potentially tap the chest. Absolutely much easier here, Dr.
All right, let's do that, Dr. Chalhoub. We're going to scan this, and keep in mind it does change, as you can see that image we saw, but we're going to talk about the position we scan most frequently in. That is a sternal or standing patient. So let's get to that caudal-dorsal site. First thing, Dr. Chalhoub, where the star is, start over lung. Absolutely necessary, and we'll show you a clip of that. And then what are we going to do?
Well, you start over lung. That's our cranial lung border. You move backwards to our caudal lung border. These are ultrasound borders. We're not making you count ribs, memorizing any protocols. We just want you to use the dog's ultrasound anatomy. You find that caudal border, Dr. Boysen, what's next?
And then we're going to go dorsally along that caudal border. So think about it. Patients in sternal standing, where's that air accumulate? Caudal dorsal. Exactly. We go caudal, and then we go dorsal. We're not rocket scientists. We try to keep this as simple as practical as possible. Go caudal, then go dorsal, and use your borders to find that. And we'll show you a video of that right now.
100%. Let's do it.
I need to get up here. So how am I going to do that? Pull the skin down, a little alcohol here, pop the probe on with a marker towards the head, separate the fur, and we're just basically going to go straight back until we find that curtain sign. Then we're going to go straight up until we lose the Pleural line and the hypaxia muscles come back down until we just see that curtain sign again and that pleural line, and we assess that region there for the glide sign. That is how we rapidly rule out pneumothorax.
All right, Dr. Chalhoub. So we went caudal, we went dorsal. That's really, really quick and easy to do. Very nice, Dr. Chalhoub.
Okay, that is very cool, Dr. Boysen. So moving on from that, we got to think about how we're going to do this, right?
All right.
We talked about a lot of things there, Dr. Boysen. I'm a little confused. I heard you talk about a glide sign, I heard curtain sign, I heard a pleural line. It's like, my head's about to blow up here, Dr. Boysen. I need to start with step one.
All right, so step one, Dr. Chalhoub, and we'll come back to that video again afterwards. So we'll go through that a second time once we've gone through and everybody's comfortable with the orientation and how we're going to do that. Okay. But essentially what we're going to do is our patient's in sternal standing. What we're going to do is we're going to put the probe perpendicular or transverse to the ribs, Dr. Chalhoub.
Okay, so we're going to put the probe perpendicular to those ribs, Dr. Boysen. That's going to be very important. We're going to talk about that pattern recognition. But if we were to do that, Dr. Boysen, we have to think about what we're going to see. So again, beginners, this is a great thing because it's all about a pattern recognition. But if you do this for the first time, Dr. Boysen, you've never done this before and you're used to the abdomen, looking at all those beautiful kidneys, the bladder, the kidneys, the bladder, the kidneys.
So there are no kidneys in the thorax, Dr. Chalhoub. If there is, you have a serious problem. It's not impossible, but it means there's really bad pathology. So we're not looking for kidneys, Dr. Chalhoub. Put that perpendicular to the ribs. What are we going to see?
Well, that's what I was saying, Dr. Boysen. Duh. It's just so different. Your expression is going to be like, what? Where in the world are those beautiful soft tissue organs? All I see is a bunch of lines. I'm thinking I see a giraffe there, Dr. Boysen.
Okay, that's quite the imagination. Even a radiologist would be impressed with that imagination, Dr. Chalhoub. But we're looking at, exactly as you said, a lot of different lines and different shades of gray. Okay. And we need to break that down because if we know the anatomy, if we know the structure we're looking at, we can identify the underlying pathologies that we're concerned about.
Well, let me ask you a question, Dr. Boysen. In the abdomen, everything is soft tissue, soft tissue. Why am I seeing everything here?
And that is because, Dr. Chalhoub, there are two enemies to ultrasound. And this is why I find this so fascinating. Two enemies to ultrasound, Dr. Chalhoub. What are they?
Okay, well, one is going to be bone. I know that ultrasound beams can't go through bone.
You are correct. And what is the second one, Dr. Chalhoub?
Well, it's going to be air.
Absolutely. So we got bone and air, Dr. Chalhoub. If you know what your actual enemies are and you know how to find the site where the probe will interact with those enemies and what we will see as artifacts, we can use that to our advantage, Dr. Chalhoub, and we can actually figure out what we're looking at and how to interpret it.
Okay, so we talk about pattern recognition, Dr. Boysen, because that's one of the reasons why I want to put the probe perpendicular to the ribs is think about pattern recognition. What are we trying to find?
All right, and when we put the probe on, Dr. Chalhoub, let's break this down. So we put the probe on at the skin interface here, and the ultrasound beam comes down, it hits bone, Dr. Chalhoub. That creates artifacts. So we get this rib shadow because that is one enemy.
Yes.
So the probe's here, it goes through the skin and soft tissues, it hits the bone, it makes a down white curvilinear structure. We're going to talk about the bat sign. That is the wing of the bat, Dr. Chalhoub.
Okay.
So ultrasound hits bone. We only see rib shadow and artifact below the bone, which we're going to call the wings of the bat. This will make sense in a second.
All right, so I get that. Now, what about when it hits that pleural line?
So anytime we go from a soft tissue to air interface, Dr. Chalhoub, we get 99.9% of the ultrasound beam reflecting back from that soft tissue air interface to the probe, and it'll bounce back and forth. So everything below a soft tissue air interface is also artifact. That is the body of the bat. So you can see that we've got a bat sign here superimposed. Wings of the bat, body of the bat. And this is important, Dr. Chalhoub, because we really want to find that soft tissue air interface with confidence. How do we do that? We find the wings of the bat and the first white line below the ribs or the wings of the bat that joins the rib shadows is the pleural line.
Interesting. So we're not actually looking for bats in the thorax. I thought that's when you were saying the bat sign, but now I get it. We're looking for pattern recognition with the probe in perpendicular, all of this to find that pleural line. But Dr. Boysen, let me ask you something. If the ultrasound beams can't go through bone and air, that means what I'm really looking at is the soft tissue muscles and all that fascia right above that pleural line.
That is the only true structure or tissues that you're able to see with ultrasound. That's all the ultrasound beam goes through. Everything down here is going to be artifact because of either bone interference or because of a soft tissue air interface, Dr. Chalhoub. That is absolutely 100% correct.
So why are we doing this?
Because we need to find, again, that body of the bat. We've got to find that pleural line because all sonographic signs arise from the pleural line, Dr. Chalhoub. And if we know where that is, we can either interpret pathology below that, or we can interpret pathology at the pleural line that represents underlying lung disease.
So if we can find that pleural line, lung ultrasound is truly a surface imaging technique.
You're getting the hang of it, Dr. Chalhoub. Even for an internist, I'm going to say you're doing well.
Well, the audience probably doesn't know that you were my professor 15 years ago. So any lack of understanding I have is probably directly to you.
Some students are easier to teach than others, Dr. Chalhoub.
I think we're going to move on. So it's important to talk about the anatomy of that pleural line, Dr. Boysen, because that pleural line in a normal, healthy animal is comprised of two linings.
Absolutely. And we're going to separate them here. You can't really see the separation on ultrasound, but we're going to separate them just to make a point.
Okay.
We have the inside lining of the thorax, Dr. Chalhoub, which is called what?
The parietal.
And that's this line here.
Yep.
And anatomically and physically speaking, or physiologic standpoint, we have a small amount of fluid separating the inside lining of the chest and the outside lining of the lung, which is called what, Dr. Chalhoub?
Visceral pleural.
Absolutely. So we got a little bit of fluid between them.
Yeah.
We don't usually see that on ultrasound. We're going to come to that in a second.
Right.
But we do have, and we're showing it for the sake of a schematic and understanding here, a separation. When our patient breathes, what happens to those two pleura, Dr. Chalhoub?
Well, when the patient breathes, those two pleura are both moving, slightly different speeds, slightly different orientations, Dr. Boysen.
Absolutely. So what actually happens is, if you take a deep breath, Dr. Chalhoub, your chest moves out in cranial, your lungs move out in caudal. So they're sliding in different, go ahead and take a breath again. They're moving in different directions, Dr. Chalhoub, and we can use that to our advantage, even if we can't see that separation between them, which would be unbelievably nice if we could.
So what I'm hearing you say is we can't normally see the separation between parietal and visceral pleura because they're separated by a tiny bit of fluid that we can't see that actually helps with respiration movement. And so they're stuck together, but the fact that they are together and because the patient breathes, then we will see a shimmer along that line, which is called lung sliding or the glide sign.
Absolutely, Dr. Chalhoub. And this has to do with the fact that you take the parietal pleura, you take the visceral pleura, you put them together, one white line because I can't see the gap. How do I know there's two pleura? Wait till the patient breathes. Now they slide. And what we're actually seeing when we see that shimmering, Dr. Chalhoub, is we're seeing one surface slide across the other. We're seeing the lung slide across the inside of the thorax. So there are two criteria that you have to have present when you see lung sliding or glide sign, Dr. Chalhoub. What are they?
Well, I would imagine that the two pleura must be in contact.
As we just said, Dr. Chalhoub, you're good at stating and copying what we just said.
Thank you, Doctor.
And the other thing, Dr. Chalhoub, you have to have that sliding. So the lung has to move. Therefore, the patient has to
breathe.
You bet, Dr. Chalhoub. You got to have the patient breathe and the pleura must be in contact. So take the reverse. If you have lung sliding, it means you can conclude your lung is in contact with the chest wall. You have ruled out all space-occupying pleurals disease.
That sounds like a bad critical care joke. The patient must breathe. I'm going to hope they can breathe.
That's a normal part of life, Dr. Chalhoub. Being able to respire in and out, that's a normal part of the respiratory cycle and part of life.
Okay, Dr. Boysen. So we have a video here on where to start.
All right, so we're going to start at that cranial border just behind the front limb, as you can see highlighted there. We put alcohol on, we separate the fur, we put the probe on the patient with the marker towards the head. That gives us this beautiful image here. We adjust the depth to 4 to 6 centimeters, as we can see now. And then again, we find that rib shadow in the rib shadow in the rib, pleural line. All right.
So that first bright white line below is going to be that pleural line. That's where we look for lung sliding. If we see it, that means the two pleura in contact, and we can evaluate lung below, Dr. Boysen.
Absolutely, Dr. Chalhoub. So again, there's that pleural line that you see, and there's the rib shadow. There's our bat sign, Dr. Chalhoub. We'll blow that up just so we can see it more clearly.
So what's really key here is you didn't guess, Dr. Boysen. You put the probe on the thorax where you knew there'd be lung using that cranial lung border, which is limited by that forelimb.
Absolutely. And if I'm really perpendicular, you can see how bright white this is now. And I can see that these reflections of that pleural line to the far field. So that's because I'm very perpendicular and the ultrasound beam bounces back and forth between the probe head and that pleural line. If I angle what we call changing the inclination, angle at which I hit that pleural line, look how oblique that is. We actually make this grainier, and the more grainy the pleural line, the easier it is to see. The other thing we can do, Dr. Chalhoub, what else can we do?
Well, Dr. Boysen, we can sit on top of a rib like we're doing right there, and that also changes the angle of inclination on either side, and it helps you see that lung sliding. You can also fan the probe or change the gain, Dr. Boysen. So here we are. We like to call this the dead bat sign because the bat, instead of being like this, is upside down, so you see its body hanging upwards, Dr. Boysen.
All right, good imagination. Once again, Dr. Chalhoub, we'll call it the dead bat sign, but you can change the angle of inclination. The idea is make that pleural line less bright white, make it grainier by decreasing your gain, by changing your angle of inclination, or sitting over one rib. The grainier it is, the easier it is to see the lung sliding of the glide sign.
I like that. So again, no guesswork, Dr. Boysen. So we started at the cranial border. Now we're going to move backwards until we hit the caudal border, which is called the curtain sign, Dr. Boysen. So let's talk about this curtain sign. I know you're a big fan of the curtain sign. Curtain sign, please enlighten us.
All right, Dr. Chalhoub, the curtain sign, this is actually quite easy to find. We'll start by putting the probe on the pleural, on the lung itself, like you see here, right behind that front limb, as you described, that cranial border.
Yeah.
What am I going to see when I put the probe perpendicular at this site here, Dr. Chalhoub?
Well, normal healthy lung, you're going to see a nice glide sign there, Dr. Boysen.
Absolutely.
Bat sign.
Absolutely. We're going to see the bat sign, and we're going to see that lung sliding. Now, let's say I slide the probe back here, Dr. Chalhoub. I am half over lung and half over the soft tissues of the abdomen.
Okay.
Interesting. What do we see when we actually hit that caudal border there, Dr. Chalhoub? So the X-ray shows it here. We're half over lung, half over soft tissues of the abdomen.
Yeah.
Here is our schematic image of the ultrasound probe that you can see.
Yeah.
We put the probe there, and we imagine some ultrasound beams coming off of that probe, Dr. Chalhoub. Here in yellow.
Yeah.
They hit, what do we hit right here, this short one?
Well, bone.
And what are we going to see?
But just bone shadow, Dr. Boysen. You're not going to see anything.
Absolutely. So that's rib shadow. We come down over here, Dr. Chalhoub.
Yep.
I am over the lung area. So this is actually going to be soft tissue air interface. Beam comes down. Will it go through that air, Dr. Chalhoub?
No, it will not, Dr. Boysen.
It will get bounced back. So I will not see anything here.
Yeah.
Let's come over to this half of the image here. We put the ultrasound beams come down. What have I hit right there, Dr. Chalhoub?
Well, you're going to hit bone again, Dr. Boysen. So you're going to get rib shadow.
Absolutely. And here, Dr. Chalhoub, I come down. I'm going through the soft tissues. What do I hit?
Well, now you're going through soft tissue to soft tissue to soft tissue. And all of a sudden, this is making sense to me again. I'm seeing structures again, Dr. Boysen.
Absolutely. So we got half of this image is covered with artifacts and I can't see anything. Half is soft tissue. And that creates this vertical edge artifact that we call the curtain sign, Dr. Chalhoub.
Oh, and it's moving in and out like one of those big curtains. So what I'm hearing from you, this is a transition here, Dr. Boysen.
Yep. So we're going off of lung onto soft tissue at the lateral caudal part of the thorax. That is the curtain sign. Try to put it right between the two rib shadows so that you don't lose this vertical edge artifact underneath one of the rib shadows.
Yep.
It's a nice place to assess it. And you can see that it is a vertical edge artifact.
Dr. Boysen, why call it a curtain sign? Why not just call it the diaphragm? I mean, that's the diaphragm, isn't it?
No, Dr. Chalhoub, think about a radiograph. When you have a radiograph, the diaphragm curves away from the chest wall. And when it curves away, what is actually going to slide in here and fill this space, Dr. Chalhoub?
Well, I'm hoping air.
So it's going to be lung. And there's not necessarily the right answer because you got to have a pneumothorax. But if you want air-filled lung, that will slide back here, Dr. Chalhoub. And as soon as you get air-filled lung that slides back here, you have air that stops your probe from coming down. So you won't see the diaphragm curving away. You'll only see it to the point where you see soft tissues. The actual diaphragm runs right about here between the abdominal contents and the chest wall.
Yeah, gotcha. So we use this as our marker for a caudal border, the curtain sign. So we went from our cranial border, caudal border. That makes a lot of sense. But Dr. Boysen, I got to think about this. This makes a lot of sense to me. I'm excited, but you told me I need to get kind of up there to really rule out pneumothorax.
Yeah, so we got to get that caudal dorsal site. So let's imagine we do that. We slide caudal, we slide dorsal. We're at that caudal dorsal site, Dr. Chalhoub.
All right.
All right. And one of the things that we wanted to ask ourselves with Kira on that right side where we had decreased breath sounds, we thought, clinical question, hit by car, respiratory distress, could we have a pneumothorax there? Yes or no? So we come up here, we're at that site. There's my rib shadow, rib, bat sign, pleural line. I'm looking at that pleural line, Dr. Chalhoub. Do you have lung sliding? Do you have a shimmer that you can see here?
You know, I'm not sure. I don't think so, Dr. Boysen, but I can't say for sure.
All right. So if you don't know for sure, then you can't answer the next question. Do you have a pneumothorax? Yes or no?
Ooh, I'm going to have trouble answering that, Dr. Boysen.
All right. And the idea is if you see lung sliding, as we said, two criteria. If you see lung sliding, it means the lung's in contact with the chest wall.
Yeah.
You can rule out with very strong confidence the presence of a pneumothorax if you see lung sliding.
Yeah.
If you don't see lung sliding, then you should think or suspect pneumothorax.
Yeah.
But we can't hang our hat on that because even in some healthy patients, and particularly in patients with respiratory distress, the lung sliding and the glide sign can be difficult to identify. And you think about this, and now I'm just breathing nice and slow, deep breath, long lung sliding. Lots of time to see that shimmer. The dog that comes in with respiratory distress because he's hit by car, that's about the distance that you're seeing the lung move along the chest wall. You're going to have a hard time seeing that shimmer because there's so little movement to allow you to do that.
And Dr. Boysen, I like to think of lung sliding. It looks a lot like water coming out of a tap. And I like to try to picture that while I'm looking at the lung sliding. And I have to say, I'm not seeing that here.
Yeah, so you don't see obvious movement of the water, but you know the water's moving because you see that shimmer.
Yeah.
And that's the closest thing. And I look over here, I'm not seeing that shimmer either, Dr. Chalhoub. I suspect a pneumothorax. So we believe it's there, but if we're not certain, we should do a rule-in test, Dr. Chalhoub.
Well, let's talk about those rule-in findings, Dr. Boysen. We need to talk about what it is, or the things we're going to talk about. There's going to be a couple of them, Dr. Boysen. So there's going to be something called the lung point, which is something they use in human medicine as well. Right? But then there's something a little newer that was just recently found.
Yeah, and that's called the abnormal curtain sign. So we talked about the normal. Let's turn our attention to the abnormal curtain sign because we just recently published this in a paper in Frontiers. It's open access.
Okay.
So you can go online and look at this if you wish. Well, let's go through this, Dr. Chalhoub. We're going to go back, like we said, caudally and then along that curtain sign.
Yeah.
And as we do that, we can look for abnormalities, Dr. Chalhoub.
So wait, there's a normal and an abnormal curtain sign?
You're getting the hang of this, Dr. Chalhoub.
Jeez.
So let's talk about those abnormal curtain signs. So here's that vertical edge artifact.
This is normal.
This is normal. So in a normal patient, do you see a vertical edge artifact, the curtain sign, Dr. Chalhoub?
Always do, Dr. Boysen.
All right. And is there only one or are there multiple vertical edge artifacts?
There's only one, Dr. Boysen.
Correct. Don't confuse it for rib shadows, but when you get it in the middle, there's one and there's only one.
Yep.
Does it ever disappear? Can you always see it during the respiratory cycle?
Unless I close my eyes, it doesn't disappear, Dr. Boysen.
Excellent, Dr. Chalhoub. So it never disappears and it doesn't slide underneath the rib when we got it in the middle there. Very good.
Okay.
So let's look at this one here, Dr. Chalhoub.
Whoa.
Do you see only one vertical edge artifact?
I think I need to clean my glasses. I'm not wearing glasses today, but no, I see two.
All right, exactly, Dr. Chalhoub. So if you compare the one on the right to the one on the left, we have something different on the one on the right than the left.
Wow.
And does the curtain sign ever disappear here, Dr. Chalhoub?
Yeah, it looks like it's playing a game of peekaboo, peekaboo with me, Dr. Boysen. It's just coming in and out.
Exactly. So I'm looking at that here. I see the pleural line. There's my rib shadow. There's my rib. I'm looking along here. All of a sudden, this soft tissue structure, it's actually liver in this case, is suddenly appearing in the middle of the air-filled space between the two ribs. That is a double curtain sign, Dr. Chalhoub, and that is abnormal. So you can see here, we've drawn the red line.
Yep.
That's our single
line
vertical edge artifact. Over here, Dr. Chalhoub, there's the two. We've got air, soft tissue, air. That is only seen in our patients when they have pneumothorax, Dr. Chalhoub.
So double curtain sign, Dr. Boysen, is synonymous with having a pneumothorax. Okay, I can get this.
All right, let's test you. Let's see if you actually did pick up on this, Dr. Chalhoub. Here we are, looking at this here. We're at the site where we are junctioning between the thorax and the abdomen. That's where we figure out the probe. We see this vertical edge artifact here.
Yep.
I'm going to argue that's the curtain sign. Is this normal or abnormal, Dr. Chalhoub?
You never told me it was going to be quiz, Dr. Boysen. Okay, I see two there, Dr. Boysen, and it looks like it disappears. This does not look like a normal curtain sign to me, Dr. Boysen. So I'm going to say yes to pneumothorax. Binary question.
All right, and the other thing you can do, don't just look at that here. Look at the pleural line as well. Do you see lung sliding or shimmering on either side of this?
I definitely don't see any tap water going through there, Dr.
No,
Boysen.
so this is actually a pneumothorax. We can look both at lung sliding and we can look for that abnormal curtain sign, and we can confirm that this is a rule in, this is a pneumothorax.
So Dr. Boysen, the other one is lung point, which arguably is maybe a little harder to see, but I think it's important to talk about that. So we have a CT image here, and on that side, we can see a big pneumothorax there with some lung down below. If we put the probe here at position number 1 here over that pneumothorax, what are we going to see, you think?
We're not going to see anything, Dr. Chalhoub, because there's no lung underneath. All we're going to see is that pleural line, soft tissues, and then soft tissue air artifact down here.
Yeah.
But there's going to be no lung sliding because the lung is not in contact with the chest wall. You can see that separated by air.
So all we're seeing is the parietal pleura, then there's air, so you don't see anything because air is an enemy.
Correct, Dr. Chalhoub.
All right, so what about if we move down here?
Well, if I come down here, I'm over lung, so I should see everything like I normally do. And when my patient breathes, even though I have a pneumothorax, that lung's still going to expand and contract. Therefore, I am still going to get movement of that lung along that chest wall. I'm still going to get a shimmer lung sliding. And if I look at this image here where my little pointer's at, I look at that. Do you see that back and forth water-like shimmering, Dr. Chalhoub?
I sure do, Dr. Boysen, all the time.
All right, so this will have a normal appearance of lung sliding here. Let's suppose I come up over here, Dr. Chalhoub.
Okay.
I am over air of the pneumothorax to start with. So I'm not going to see anything other than that artifact and a single pleural line, no lung sliding. But I'm actually at the point where the lung's transitioning into contact with the chest wall.
Okay.
My patient breathes here, that lung expands and slides across my ultrasound image, Dr. Chalhoub.
So you have a glide right then and there.
So then you will have lung sliding. My patient's going to breathe in and out. That lung sliding is going to appear and disappear, Dr. Chalhoub.
Whoa. Okay. Well, when I'm looking at that on the live patient, Dr. Boysen, someone looks like a karate chop coming in. Hi-ya!
All right.
It just retreats itself.
So we look at the point where the yellow arrow is. There's the pleural line. Above that, there's no lung sliding. I've got an absence of anything up here. There's always a pneumo. Down here, it starts as a pneumo, and then the lung slides in, or as you say, it looks the appearance of a
karate chop.
Okay, Dr. Chalhoub. We've turned the image sideways just so it makes it a little bit easier to understand how that's lung sliding up and down.
So it's essentially an intermittent glide that we're seeing there.
Yeah, it's a partial lung sliding across part of the image. Okay, because a lot of people think any lung sliding rules out pneumothorax. No, partial lung sliding over half of it when you're at the lung point actually rules in pneumothorax.
So it's the actual point where you're seeing the two pleura recontact each other.
That is correct. Actually, we get the hang of it.
All right. So if that patient is sternal or standing, Dr. Boysen, I was at caudal dorsal, I see no glide, I should probably come cranial ventral because that's where the lungs are going to be squished to try to find for that lung point.
You nailed it, Dr. Chalhoub. And if I look at this image here, there's my rib shadow, there's my rib. I've got some pleural line here, and I don't see any shimmering over here at any point in time on this side of the rib.
Yeah.
I come over here, I see no lung sliding there.
Yeah.
Then all of a sudden I see in and out, Dr. Chalhoub.
Oh, yeah.
Lung coming in and out. We found the lung point here, Dr. Chalhoub.
Dr. Boysen, I got to ask you something. Is this a Jedi lightsaber fight that's going on here? I just see a whole bunch of, lightsabers, Luke Skywalker.
Okay, Dr. Chalhoub. So you're correct. Why is it that we're seeing these vertical white lines underneath that lung when we're seeing that side of recontact? So let's talk about those. Those are actually B lines, Dr. Chalhoub.
Oh, okay. So those are called B lines, which are also called lung rockets, comet tails, ring down artifact, and they occur when fluid and air are next to each other at the lung surface. Now, they can occur naturally, Dr. Boysen, in cats and dogs, but in a small number.
Absolutely. We'll only see up to 3. It's rare to see 3. We're more likely to see only 1 or maybe 2 at a single or 2 sites on a thorax. And we can see that in 11 to 31% of dogs and a similar number in cats. So that is what we're looking for, is this vertical white line, Dr. Chalhoub.
Dr. Boysen, I really think we should change the name. Lung rockets? No. This is definitely lightsabers there, Dr. Boysen, because look at that. It totally looks like a lightsaber coming down. Luke, I am your father. No?
You got to get the voice,
I can't get it there.
Earl Jones.
I keep trying.
No.
It just doesn't go very well,
All right.
Dr. Boysen.
So point is, we get these vertical lines. So let's talk about the specific criteria that we have when it comes to B-line identification.
Okay.
As we said, occasional is normal, Dr. Chalhoub. You
Yep.
can see that here. We're seeing a vertical white line as opposed to horizontal white lines, which we call A lines. We didn't go into detail on that,
Right.
but these are vertical white lines, Dr. Chalhoub.
Laser-like lines, Dr. Boysen. They're vertical. And Dr. Boysen, they originate from the lung surface, which is very important because we can actually use that. If they originate from the lung surface and we can see them, Dr. Boysen.
Yep. And if they're at the lung surface and at the pleural line, that means by definition, the lung surface has to be at the pleural line because the B line's at the pleural line. Therefore, B lines rule out pneumothorax, Dr.
Exactly. Because if it was air between the two pleura, you wouldn't see them, Dr. Boysen.
That is correct.
All right. I like that, Dr. Boysen. They move the pleura, as you can see, they're back and forth, which makes sense. Again, they're coming from the lung surface, that visceral pleura, so it makes perfect sense when the animal breathes. And they extend to the far field. We have our centimeter scale on the side there, and you can see we're at 5.8 centimeters. We're seeing very nicely there, Dr. Boysen.
All right, excellent, exactly, 100% agree. So make sure all those criteria are there. And if we have A lines, we don't see any A lines in this image here. Again, it depends how you angle the probe to hit the lung surface on whether you'll see those A lines or not.
Yeah.
We can actually, if we did have them, this would obliterate and cut through those. If they were there, it tends to make them disappear.
Obliterate like a lightsaber, Dr. Boysen.
If you wish, Dr.
So why are we talking about this? Because important as clinicians, we have a patient that's coming dyspneic, tachypneic, triage. One of the things we're going to wonder, does they have dry lung or wet lung, right? That's going to be one of the big things we want to answer really quickly, and we can do that with ultrasound, Dr. Boysen.
So first thing I got to think about, if I'm going to say whether that lung's wet or dry, I need to know that that lung is against the chest wall. Therefore, I need to be able to confirm the presence of lung sliding or glide sign. First thing I have to do, and if I look at this image down here, do you see a shimmer, Dr. Chalhoub?
I sure do.
Therefore, the lung is in contact with the chest wall. I can now interpret that lung as being wet or dry.
100%. Then we want less than or equal to 3 B lines at the probe location, or only A lines visible, which means there's no B lines. And then that combined together equals dry lung, but just at the probe location, Dr. Boysen.
Right, at that single window, because we're going to talk about the definition of increased B lines when that becomes pathologic.
Yeah.
And we'll do that within each window, and we'll do that across an entire hemithorax.
So Kira, we talked about on the right side, quiet lungs, left side, there were crackles, Dr. Boysen. That makes sense if we're thinking about wet lungs.
Yeah, and if we're thinking a date by car, I'm thinking, wow, maybe there's some blood in the lungs. Maybe we got some hemorrhage in there in the lung itself, not in the pleural space, but in the lung itself. We got bruising, we got contusions. All right, let's see if we can break this down then. We put the probe on. We already did the right side of Kira. We had a pneumothorax. We picked that up with lung ultrasound in a matter of seconds. We're going to scan the left side now. We got crackles. We put the probe on. I can see the rib shadow there that's labeled, the black going up. There's my rib, pleural line, Dr. Chalhoub. Do you have back and forth movement along that line?
Well, I sure do. And it actually really helps because I have those B lines right there, Dr. Boysen.
All right, so we got lung sliding. Do you have a pneumothorax, Dr. Chalhoub?
I do not.
Because B lines and lung sliding, both with confidence, rule out pneumothorax at that probe location. And Dr. Chalhoub, my next question then, since you said you saw B lines, how many do you see in this ultrasound image here?
Probably a bazillion gillion. Zillion.
All right, so we got an increased number of B-lines. We've got at least probably 10 here across this entire window. And we like to say that number of B-lines not between rib spaces because our animals are such different sizes, between a Great Dane and a kitten, for example. So we like to count them across the entire window. Do you have more than 3? Yes, this by definition is pathologic increased B-lines. We have pathology in the lung, which is being interpreted at the lung surface.
That's right. And Dr. Boysen, so now we're going to come into dry versus wet lung. Wet lung, we're going to talk about regional lung scanning. Again, we're not going to make people memorize any protocols. We're going to come back to those borders, Dr. Boysen.
Absolutely. And everything between the borders is going to be lung. So if you know your borders, everything in between is lung, Dr. Chalhoub.
Yep.
All right, so let's talk about that. How do we start, Dr. Chalhoub? We're going to start at the same spot where we look for pneumothorax. We go caudal, and then we go dorsal. We're at that caudal dorsal site. Where do we go from here?
Well, then we want to regionally scan the lung. The best way to do this is if you do an S-shaped scanning from caudal border to cranial border down, and then back to caudal border down, and then back to cranial. S for Serge. I love it.
Or save the animal.
What?
Or CERN?
No. And if you do this, then you scan multiple regions of the lung in a relatively quick, systematic fashion, be able to assess the lung for being able dry or wet. But Dr. Boysen, we should include another site.
And the other thing we need to do, there's a beautiful window into the caudal part of the thorax, and that is through the acoustic window of the liver. So we include the subxiphoid site, and it gives us a beautiful view of the pleural space, the pericardial space, and the caudal lung surface in contact with that diaphragm that we can't see from either side. We have to come in on midline.
100%, Dr. Boysen. I love it. So greater than 3 B lines in a single window is pathologic for increased lung fluid. And we're going to call that alveolar interstitial syndrome, or AIS, Dr. Boysen. Now, I got to ask you a question. I see it here in transthoracic there between 2 ribs. I also see it in the subxiphoid. Whoa, there's so many there. But Dr. Boysen, I'm just getting very confused here. You know, I need to assess it in more than one location.
Yeah, so we look at and we answer the binary question at each window we scan. Do you have 3 or more B lines, or do you have more than 3 B lines? Yes or no?
Okay.
So in this example here, do you have more than 3?
Yeah, absolutely.
That's 1, 2, 3, 4. That's higher than normal. Do you have more than 3 at the subxiphoid?
I have 100 bazillion mazillion.
So at these 2 windows, these are wet by definition. That's pathologic for that patient.
Okay.
But there are situations where we can have a normal number, but how many windows should we have? 1, 2, or 3, Dr. Chalhoub?
Oh, just a couple tops.
So that's exactly it. We got to do an entire lung scan, assess each window, and then put it together, create your plus profile, combining all of your windows to say whether that's wet or dry. So here is our binary question at each window, Dr. Chalhoub. You have lung sliding. Are we wet or dry at each window?
Looks like dry. I don't see a single B line there, Dr. Boysen. So this plus profile for this side of the hemithorax, I would call this dry lung.
You nailed it, Dr. Chalhoub. So let's do another one. Let's scan this patient again. We're doing each window. What do you think at each window? Are you dry or wet?
Well, only one window where I see 3, but by definition, that is okay, especially that it's only one single window, Dr. Boysen.
You're correct, Dr. Chalhoub. 3 is rare, but can occasionally be seen. So consider the history, consider the big picture, but putting that together in this patient, seeing only one site, I would agree. And if the other side particular is also completely dry and there's no history of trauma or anything, this would be a dry plus profile, even though we found one site with 3.
All right, Dr. Boysen, let me put up this one for you here, because I see 1 B line on top there, then dry, 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 a couple of B lines there, then nothing, and then a couple of B lines there. So at each window, this is considered dry.
Absolutely. And that's why we're now creating that plus profile. We have to consider how many B lines there are at each window on a hemithorax and on both sides of the chest.
Okay.
And then if you look at the human literature, we don't have the exact numbers yet in the veterinary side, but in generally speaking, if you've got more than 2 sites that are positive on both sides of the chest, it's pathologic.
In humans.
For alveolar interstitial. And that's the consensus on the human side. And we have a similar consensus on the veterinary side. More than 2 sites on both sides that are positive, that's pathologic. Or we could say if you have 3 or more sites that are positive on one side of the chest, seriously think about that in light of the history and clinical findings, because there's a good chance that's pathologic as well. So can you create that plus profile, putting all the information together, not just one single window at one site.
So concerning for wet lung on this side of the chest here.
In this patient here, because we got 3 positive sites, even though each one is individually normal, combined, yes, Dr. Chalhoub.
So, Dr. Boysen, let's say I got a dog that comes in vomiting, then whoa, it's dyspneic and tachypneic, and I'm doing point of care ultrasound, dry. Whoa, one spot where I see 4 B lines. What is that?
Yeah, a lot of people might think, well, it's only one spot. It's not a big deal, but it meets the criteria of more than 3 at that single site. That means this side is chest has pathology in it.
Yep.
In this case here, it's a cranial ventral pattern.
Yeah.
And therefore, that distribution is also helpful. I would worry most and foremost in this patient about aspiration pneumonia, Dr. Chalhoub.
Okay. So again, you got to put it all together into this plus profile, not just each site, but you got to assess each site.
Yes, Dr. Chalhoub, we have to look at each window in each site. That is absolutely correct, Dr. Chalhoub.
All right. So Dr. Boysen, let's go ahead and talk about abnormal lung ultrasounds, B lines a little further. So the appearance can really vary with the number, right? What does that mean? I mean, sometimes you have 5 or 6 Jedi Lightsabers. Sometimes you have 20 and it's an epic fight.
All right, Dr. Chalhoub, we're going to go through this. And we have this argument every single time. And for some reason, you just don't seem to pick up the fact that these are not lightsabers. I'm going to explain what they are in just a second. But if we look over here, Dr. Chalhoub, I see the pleural line. I see the rib shadow.
Yeah.
And I look here. Do you see vertical white lines?
I sure do.
Do you have a pneumothorax, yes or no?
You do not have a pneumothorax.
And do you have an increased number of B lines?
Yeah, I probably see 5 or 6 there, Dr.
All right, so this by definition is pathologic. We've got alveolar interstitial syndrome at this window. It's probably equivalent to, on a radiograph, say the site number 1 labeled here with the ultrasound.
Yep.
So there's alveolar interstitial. If I look at this one here, Dr. Chalhoub, there's my pleural line. Do you have increased B lines?
I have a lot of B lines there, Dr. Boysen, certainly more than number 1.
Absolutely. And therefore, this is going to be wetter lung. In the actual lung parenchyma itself, it's going to be edematous and wet.
Yep.
This is going to be more equivalent to site 2 here on the radiograph.
Okay.
This is worse than it is on the left, Dr. Chalhoub. So
Okay.
the more water there's in the lung, the more B lines that we're going to see at the lung surface, Dr. Chalhoub.
Okay.
And now, as I said, look like lightsabers, Dr. Chalhoub. These are rays of sunshine from the heavens through the clouds. And I was hiking with a buddy of mine down Lewis in the Lake District. He's like, wow, that's a nice sunset there, Dr. Chalhoub. I'm like, holy frick, those are B lines. I need that image. Come on. Lightsaber? Like, yeah, I'm glad you agree with me. Finally, Dr. Chalhoub, thumbs up. This, look at it. Look how similar that pattern is. And now everywhere you go walking in the backcountry, when you see those rays of sunshine from the heavens, Dr. Chalhoub, through the clouds, you'll think, B lines.
I'm sorry, is that another bad critical care joke? If you see the heavens, your patient is closer to heaven?
It means there's more water in the lung, Dr. Chalhoub, but it's an interesting point. We'll come back to prognosis shortly.
Okay, Dr. Boysen. So like we said, this indicates AIS, alveolar interstitial syndrome. Dr. Boysen, do we reinventing the wheel here? Is this a completely set of differentials from radiographs?
Nah, and this is why I love it. We've all been trained as veterinarians. It's part of our veterinary schooling to know how to interpret radiographs.
Yep.
If I see a radiograph and I see this pattern here, it's an interstitial alveolar pattern.
Yeah.
We're all familiar with that. We all know what to look for. We all have a set of differentials based on history, clinical, and radiographs for what this represents.
Yeah.
And this is why I love it. If you see increased B lines like we do in both these images here, it's equivalent to an increased alveolar interstitial pattern on radiographs.
What?
We're using 2 different modalities to identify exactly the same thing in our patients.
So how do you know the cause?
So we, just like a radiograph, Dr. Chalhoub, is actually equivalent. What we need to do is consider the history and physical exam findings. Dog comes in with vomiting, cough, dyspnea. What are you thinking with that history of vomiting?
I'm going to think about aspiration pneumonia.
You nailed it, Dr. Chalhoub. Let's do another one. This big dog comes in after being hit by car, B lines all over one side of the chest.
Well, of course, I'm going to think pulmonary contusions.
So just like a radiograph, if I showed you this radiograph and gave you these histories, you could put it together and tell me what the likely underlying cause was. Same thing here. I don't need the radiograph. Same exact pathology we're looking for, just 2 different modalities to do it.
And you know what I love about point of care ultrasound? It's easy peasy. You're going to put that probe on there. You're going to see those B lines done. You don't have to move the patient anywhere. Patient stays more stable. You can do more things and find out faster what's going on. But again, Dr. Boysen, let's come back to the amount of B lines. And you were talking about potentially more wet lung. What are you talking about there?
Yeah, so if I go from left to right, A, B, and C, I got 1 B line here. I got multiple individual B lines here. There's so many B lines now. They're all stuck together and coalescing as a sheet.
Wow.
So I've gone from 1 to multiple, so many it forms a sheet. So I go up in severity, it means there's more fluid in the lungs. But Dr. Chalhoub,
that doesn't sound good, Dr. Boysen. Does that tell me anything about prognosis?
That's exactly why we got to come back to the same thing on a radiograph. It's the same situation. I'm going to take the example B here. I've got individual B lines. Let's say I have 2 different patients that come in, I pop the probe on and I see exactly the same number of B lines. But this patient has congestive heart failure. First time, never previously diagnosed, comes in for the first time with congestive heart failure. This patient that has these B lines has aspiration pneumonia, ARDS, and is septic. It's on a ventilator, Dr. Chalhoub. They have the same amount of water in the lungs. Do they have the same prognosis?
Well, considering that dog on the vent is on your service, likely no, not a good prognosis. I'm just kidding. But likely the congestive heart failure, because I know I could probably, I hate to say the word fix that, but I can really improve that really quickly with some diuretics.
Absolutely. So the number of B-lines correlates to the amount of water in the lung, but the prognosis varies by underlying cause.
Oh, gotcha. Now, Dr. Boysen, can I also use point-of-care ultrasound to track my therapy?
You know what, Dr. Chalhoub, if we can look at this and say that the amount of B-lines correlates to the amount of water, let's take the flip situation here and say we get a patient comes in with C full of B-lines because he's coalescing and it is congestive heart failure.
Okay.
I start my therapy. What are you going to treat him with?
Furosemide.
And we see that that lung is improving. We're getting these individual B-lines. Do you think we're getting better in terms of the amount of fluid in the lung?
Yeah, and the dog clinically too is probably going to be better.
Absolutely. So we can follow, and then we get to dry lung. We can adjust medications and we can track things serially over time based on how it changes from baseline in response to our therapies.
Wow.
We can take the flip side, Dr. Chalhoub, and say, here he is dry. You see him on the ICU service, you start pumping him full of fluids. How much fluids are you giving him?
1,000 mils per kg over 5 minutes times 3, Dr. Boysen.
And he's going to end up like it's a number C.
What?
So we can track serially for response to therapy, either good like furosemide or bad because Chalhoub is giving it fluids.
You're saying that's a bad amount of fluids?
I'm saying 1,000 mils per kg, 5 minutes repeated 3 times is a little too much fluid, and we will actually see it get, though. Not to worry, we can pick that up.
Okay.
Hopefully earlier than C. We can pick it up at B.
That's why they don't want me to work emergency anymore. All right, Dr. Boysen, there are some limitations, though, to lung ultrasound. It's important to note that it can only detect lung injury at the periphery.
Absolutely. And if you don't have the research on this on the veterinary side yet, again, we're extrapolating a lot from the human side. But most human pathology that causes alveolar interstitial disease reaches the lung surface, 95% of it. So even though we're not seeing the lung itself, we can interpret artifact at the lung surface through B-lines that tells us what's going on in the lung through those increased B-lines.
That's really cool.
If that holds true in veterinary medicine as well, and we believe it does, 95% of the pathology that would cause wet lung or alveolar interstitial disease will be represented through increased B-lines at the lung surface as we see here.
Gotcha. But it's important to note that there's some things you may miss because if they don't reach the lung surface, like we have this nodule here, well, then all you're going to see down below is because you're going to have air between that nodule and the ultrasound probe in between the pleural. You're not going to see that, Dr. Boysen. All you're going to see is just a normal glide sign.
Yeah, so if I look up here, I got a little yellow arrow separating that tissue of abnormality from the lung surface because it really is a lung surface imaging technique, Dr. Chalhoub. So if it doesn't reach the surface and there's air separating it, all I'm going to see is a soft tissue air interface. Even with the lung sliding, I might miss the pathology in this lung that's moving back and forth, but still separated from the lung surface.
Right, because air is an enemy there, Dr. Boysen.
You bet.
All right, Dr. Boysen, time for a summary. We're just finishing up. Occasional B-lines here and there when it comes to B-lines is A-okay.
Yep, less than 3 at a single site, as long as it's only 1 or 2 sites. Remember to consider that individual window, but also consider the hemithorax, both sides of the chest, and all of the history and physical exam findings.
Yeah, but then increased B-lines indicates alveolar interstitial syndrome greater than 3 per site and or multiple sites affected. Like we talked about, you need to consider that history, physical exam findings, and distribution to know what you're talking about there.
Absolutely. And this is where the coughing comes in, and I find it really, really helpful for us to put a point-of-care ultrasound on a dog or coming in, or even a cat coming in for coughing. We can actually figure out what's going on. So let's say we got a dog comes in coughing. He's got diffuse bilateral B-lines. Again, distribution is also helpful. What's your number 1 thought in this, Dr. Chalhoub?
Well, it's likely going to be congestive heart failure. But the cool thing is, Dr. Boysen, point-of-care ultrasound, we can also look at the heart.
You bet. We don't have time to do that in the hour. It usually takes us about 7 hours to get through all of the point-of-care ultrasound that we want to talk about. But you can absolutely assess the heart as well. Nicely done, Dr. Chalhoub. All within about a minute and a half. And we can say, well, this is congestive heart failure.
Yep, that's right. And then if you have a patient coming vomiting, coughing, cranial-ventral distribution of those B-lines, you're going to be thinking aspiration pneumonia.
Absolutely. And it can often, again, as we said, be unilateral in some pathologies. For example, hit by cars, you may have one side affected more than the other. So keep that in mind as well.
Yep. And then just finishing up with pneumothorax summary. If you see B-lines, that rules out pneumothorax at that site.
And glide sign, if you see that, it rules it out. But if you don't see a glide sign, then you should suspect pneumothorax because it might mean that the lung is separated from the chest wall. If it's got A-lines, sorry, I missed that one up. If you've got a glide sign, it rules out pneumothorax at that site.
Correctamundo.
If it's only A-lines and no beans, it's dry lung.
Dry lung.
If you have A-lines and no glide sign, like we have here, then you should suspect pneumothorax.
Yeah, and then you got to go in for those rule-in findings. We talked about the lung point. You see that. That is a definite rule-in finding. And if that lung is injured, coming back in, you might see beelines like we talked about with that hit by car dog.
Yeah, we look up here. I can see it's coming in right at the center here where my marker is. I see that lung sliding coming in and out.
Yeah.
Over here, no lung slide, no lung slide. This is a lung point. Not that typical karate chop up and down, but a central point that comes in for that lung point.
Yeah, it's like a double karate chop. Hi-ya!
And that actually confirms pneumothorax, Dr. Chalhoub. The other thing we look for is those abnormal curtain signs, Dr. Chalhoub.
Yep, absolutely. Abnormal curtain signs. We talked about the peekaboo this time. There's some other abnormal curtain signs as well that we didn't talk about today. And on that, Dr. Boysen, we'd like to say a huge thank you so much to our audience. We hope you enjoyed this. And hopefully you can become as passionate as we are about point of care ultrasound.
It's almost limitless what we can do as an extension of the physical examination to figure out what's going on. We can see that we got a heart here that you can also pick up. We can do that in a matter of seconds. We can actually assess multiple things. We can also rule out pericardial effusion like you see here. This dog here, we got the probe on him. He's got fluid in the abdomen. Million things we can pick up in a matter of seconds, all under 5 minutes, simply by reaching out, putting the probe on like you see, and having an iPad or an iPhone available to assess what we're looking at. It's truly amazing what we can do.
In case you're wondering, that dog has DCM. That's why we're looking at that heart's contractility. This is a short axis mushroom view. And this is, again, something you can do point of care ultrasound. We're not going to make you cardiologists or radiologists, but you can certainly look at this.
All right. And on that note, we'll turn it back over to Oran. I think he's going to do some more live demonstrations with you guys.
Yeah. I just wanted to show, I've scanned a lot of humans, it's true, but to show how quick and easy lung ultrasound is, because we love it in humans too. I want you to talk me through scanning a dog.
Yep.
There you go. Okay, here we go. This is Bourbon. Okay, great. And look at that. Even a ER doc can do it. Okay, so here's our rib shadow right here and here. There's pleural line. So maybe if I zoomed in a bit, you would see kind of a miniature bat, you would call it maybe.
Perfect. I love the miniature bat, the baby bat.
Yeah. All right. And then I would kind of move up towards try and find the curtain sign. I guess, do you alcohol all the way along to find or
you can move the skin. So you wet one spot and you can move the skin backwards. That's another way to reduce the alcohol content. And
yeah. Okay. Get
in the abdomen.
There's my curtain. There's my curtain. Oh, yep. Here we go, Bourbon. There we go.
And that's the reality of dealing with veterinary medicine. Your patients are often getting up and moving around, but that is something that we do. There's your curtain right there.
There's my curtain right there. Yeah, there's the solid, the tissue and the lung. Okay, perfect. Great. And then from there, I would just, do the zigzag down, follow the border and really follow all of that all the way in. Great.
First, you would actually want to go dorsally, find that dorsal border, which is essentially the facial muscles, so that you're going to.
Here you go. You slid off, come back down ventral till you just see the pleural line again.
There you go.
Yeah, perfect, right there.
Now you start the big S. Yeah.
And you can see the shimmer right there, the glide sign. So no pneumothorax. There's my curtain, and we saw the bat. That's great. And there's the bat. Great.
You didn't memorize a single thing. You were able to do that really quickly.
Yeah. If I can do it, I think others who are used to dealing with dogs probably can too. Okay, great. Thanks so much, guys.
Well, thank you.
And,
that was awesome.
Before we I know it was a long presentation, and before we get to Q&A, it will probably extend over time-wise for the Q&A, and we have a lot of questions coming in. So if everyone will stick with us for a couple minutes afterward, we're just going to hand it over to Janez to take it home. And then if you guys are okay to hang out for another 10, 15 minutes for Q&A, guys. Soren and Serge?
You bet.
100%.
Okay, great. So yeah, keep the questions coming. We'll let Janez take it home, and then we'll hang out for Q&A. Great.
Thanks, Dr. Frankel. Nice job. Nice job, Bourbon. And thank you, Dr. Boysen and Dr. Chalhoub, for sharing your ultrasound techniques and your super practical and, dare I say it, fun presentation today. Before we start our live Q&A session, I'd like to take a minute to introduce you all to Clarius HD Vet for the highest definition wireless ultrasound imaging to speed diagnosis for small, medium, and large animals. Our C7 convex vet scanner is specifically designed for clear clinical imaging for small and medium animals like cats and dogs. We also have the C3 convex vet for large animals and the L7 linear vet for equine. Our family of vet scanners delivers several advantages. Clarius is unrivaled for high resolution imaging in handheld ultrasound with dedicated animal presets. It shows you the fine details you need to quickly investigate an area of concern and make a confident diagnosis on your patient's first visit to expedite the right treatment plan. Each scanner is designed with 8 beamformers that deliver the image quality and speed only found in traditional systems, but at a fraction of the cost. Artificial intelligence replaces complex knobs and buttons, making our scanners fast and easy to learn and use. Your Claris scanner comes with a free ecosystem with 0 subscription fees that includes free friendly apps for your iOS or Android devices with free updates, unlimited cloud storage to capture and manage your exams, and for unlimited users at no additional cost. Claris Live delivers one-click telemedicine so you can share live scanning with a colleague for a second opinion. Claris is also wireless with 0 footprint for high portability to scan animals where they are without having to move patients in distress. You get free movement with no more wires getting in the way or startling the animals, also making it so much faster to clean and disinfect. With increased ultrasound billings, you'll see a rapid return on your Claris HD Vet scanner, which is ultra affordable. Now, just a quick poll before we begin our live Q&A with Dr. Boysen and Dr. Chalhoub. We have just one question for you today. And the question is, what additional information would you find helpful? Go ahead, this is a multiple choice question, so you can select any of these that you'd like. If you'd like to get a quote, pricing does differ by region, and we have it available in a variety of currencies. So please go ahead and select get a quote and pricing. If you'd like to speak to one of our experts and have questions about our ultrasound scanners, please go ahead and select that option. You can book a Claris demo, and we'll do live scanning for you one-on-one in a Claris demo. Please go ahead and select that if you're interested in a one-on-one demo. If you'd like to discuss features and compare it to perhaps a laptop system that you have in your practice, go ahead and select that option. And if you'd like to watch some more video tutorials, please go and select that. So many people are voting. We've got just hundreds of people here today, so I'm just going to give you 5 more seconds to vote. And so that is 5, 4, 3, 2, 1. 2 more seconds. There's so many people voting still. 1, 2. All right, so I'm going to go ahead and close this poll, and you can go to our website at any time if you want more information from us as well. Okay, now on to our live Q&A session. I'd like to welcome all of our doctors back. Please use the Q&A icon in the menu bar to ask your questions for Dr. Boysen and Dr. Chalhoub. I'd also like to invite back Dr. Frankel to moderate our live Q&A session.
Yeah, happy to. And we'll try and get to as many of these as we can. There are quite a lot here, so let's just jump right in, guys, if you're ready.
Ready.
Okay, so first one was, is there a way to differentiate pulmonary mass from a pulmonary contusion?
Absolutely. And we didn't have time to go through that, but when it comes to pulmonary contusions, what we're often looking for is the distribution of the pathology. So with contusions, we're often to get both hemorrhage and bruising in the lung, which will lead to increased B lines. So we'll have wet lung, as well as what we call consolidation. We didn't have a chance to go through consolidation, but when you get a region of lung that has less than 5 to 10% air in it, the actual ultrasound beam is no longer reflected back from the lung surface, but penetrates through the lung, and we see the lung tissue itself. So in the cases of contusions, we'll often get multiple B lines coming to a point where we'll also get consolidation, depending on how severe they are. So that is one thing that we'll look for, is the combination, and that's why that plus profile becomes so important. We see B lines and areas of consolidation. Whereas if we've got masses that reach the lung surface, in those situations, we usually find, and there's different types of consolidations, there's 4 that we look for, but in that type of consolidation, we'll often find just the region of consolidation where that mass is actually occupying and distributing the air and moving it out of the way. So you got so little air, you see it as a mass, and often that's without the B lines. Yep. So it's a combination of how you put together the profile in terms of B lines with areas of consolidations. And if you actually have nodules, then they actually form a perfectly semicircular smooth border between the area of consolidation and surrounding aerated lung. Whereas if you get things like contusions from trauma, like hit by car, then in that situation, often we get what we call a shred sign, and the border between the consolidated and aerated lung is very ragged, like ripped paper, forms a very irregular edge. It's actually, we have a really nice talk on it that clarifies all those different things, but unfortunately we didn't have time to go through it. But to answer that in a simple answer, yes, you can tell the difference. Consolidations and B lines and how you interpret them is how you do that.
Great. And then I guess maybe a similar question is differentiating. So another thing we didn't talk about was pleural effusions, really. So can you talk a bit about differentiating pulmonary edema from effusions or other fluid collections, like when somebody asks about a chylothorax as well?
Yeah, so pleural effusion is going to separate the two pleura versus pulmonary edema is going to be water in the lungs. So water in the lungs, just like what we talked about. Again, we didn't give all the information, but I think enough to whet everyone's appetite and get started. But you're going to see those increased B lines. So that is fluid in the lung. When it comes to pleural effusion, what you're going to see is a separation of the two pleura. Most of the time, you're going to see the parietal and visceral pleura separated because that fluid conducts ultrasound beams. So versus pneumothorax, where you don't see the visceral pleura, here you will, unless there's so much fluid that the visceral pleura is like really far down and you can't go that deep. So that's the difference there. Now, in terms of the type, you have to tap, right? In terms of how to get there, you guys all saw that with patients sternal or standing, we will go caudal dorsally when it comes to pneumothorax. In pleural effusion, we're going to do the opposite. We're going to hit our caudal border and we're going to go ventral. Now, again, that's another section of talk that we do. There's some techniques that can you do, like rotating the probe from perpendicular to parallel to look for smaller quantities of fluid, because then you change the way the angles of the ultrasound beams go in there. But yeah, so essentially it's the same thought process. You're using your borders. You go from cranial to caudal, caudal to ventral, boom. That's going to be the most sensitive site to find pleural effusion. Is going to be a separation of the two pleura versus B lines, which is fluid in the lungs like pulmonary edema.
Great, great. How do you identify a diaphragmatic hernia?
So now that one's more challenging for sure with ultrasound in terms of looking for a break in the continuity of the diaphragm itself. But the diaphragm, it's a bit interesting because it's not actually the diaphragm we're seeing at the subxiphoid when we scan there. Yeah. It's the actual artifact between soft tissue and air that creates that reflection and bright white line that we interpret as the diaphragm at the subxiphoid site. What we do more classically and what we train our students to do is look for, again, below the parietal surface of the chest, when you have the probe on there, look for abnormal structures. So Serge was a bit facetious when he said he didn't see a kidney in the chest. That's what we do. We start to look for loops of intestine and intestinal wall in the thoracic cavity. We look for the liver in there. So we're looking essentially for abdominal organs that are separating the lung from the chest wall and the heart from the chest wall. Yep. And some of those we can see through, like the liver, and then we'll actually see the heart. We'll actually see chest wall, liver, and heart when we have that diaphragmatic hernia, or we will see a wall of intestine or the stomach and then gas. So it can be challenging, but most of the time we look for abdominal structures in that pleural space.
Mm-hmm. Great. And there's a lot of probe questions. So do you use, we were using the C7 vet today to do the demo. Is that what you use for lungs? And do you use it for other diagnostics as well, or procedures, the same probe?
Yep. So we use this very probe for everything we do point of care ultrasound. We almost never switch. So we use it for abdominal point of care ultrasound. There's a lot of applications there. We use it for lung and pleural, like you just saw. We use it for the heart as well. So we use it for all. The biggest thing is we're going to change our depth, and we're also going to change the gain. Those are the big things we change. Sometimes we play with the frequency, but honestly, not that often when it comes to point of care ultrasound. Most of the time, we're just playing with depth and gain, depth and gain. But no, and even ultrasound guided synthesis, we use that same C7 probe. That microconvex curvilinear probe is what we call our workhorse.
Absolutely. And all the images you saw, including the abdomen and the cardiac at the end on that question slide, was also done with the same microconvex. Yeah. I would say the only time that I really prefer a linear would be if I'm doing vascular access. So when I'm doing ultrasound guided vascular access, that's when I really prefer the higher resolution of the linear probe,
higher frequency
at the higher frequency. Yeah. That's probably the only time that I prefer that. And then even saying that, if I don't have it, I will use a microconvex to do my vascular access as well.
Yep.
And I love this because, you know, in humans, we just have one human of different sizes. But what about different animals? Like, can you take the probe? One of the questions was, could you, use the same probe in equine practice or for larger animals, or what's the limitation of this one?
Yeah, so that's one where you're going to get dropout. We have done a little bit of research. Most of the research I've done on the large animal side has actually been with foals. But I will say that we can use the ultrasound probe. The difference is when you're thinking about the thorax of a horse, and you're thinking about the dropout effect on all of our ultrasound probes, no matter what machine we're working with, there is a limitation to the depth. The Clarius is actually nice because it actually does have a pretty deep penetration that you can see with. A lot of machines are going to have a dropout at about 10 to 13 centimeters. Therefore, if you're scanning the abdomen in a horse, you're limited to that 10, 13 centimeter range. You're not going to see anything deeper than that. So if you're thinking about splenic entrapment, or you're thinking of some of the causes of colic, and you're going to look for the kidney, sometimes all you're going to see is the surface, and you have to make an interpretation of whether that pathology exists or not just by looking at the surface of a certain organ, not being able to see the entire organ itself. And we actually do, we just submitted it to the AAP meeting for the equine person that asked the question. There should be, hopefully it'll get accepted, an abstract that actually is looking at some of the organs that you can look for on the equivalent of the point-of-care ultrasound, the flash exam in horses, the focused equine colic evaluation. So that should be at that abstract, and you can see what we can look at there as well.
And I think when it comes to like tendons and other things, I think, yeah, maybe for horses, they'll probably want more the linear probe.
Absolutely.
But again, that's out of our realm. But I know that our equine practitioners, yeah, I mean, that's what they use often, is more of a linear probe if they're using it more for, you know, lameness issues.
Yeah, the tendons for sure. And the linear is definitely what you're going to want for that.
Great.
But you guys do have a linear probe that you make as well, I understand.
Exactly.
Yeah, we've got the linear for vet, for equine. And then we've got the C7 for small and medium animals, and we've got the C3 for larger animals.
Another question that came up a few times was in terms of what to use. We moved the skin and we put some alcohol. Do you guys like alcohol? Do you like ultrasound gel, or do you ever mix them? What do you suggest?
Yeah, so that's a great question. Most of the time we're going to use alcohol, and Dr. Boysen was once fired from the ICU for using too much alcohol on a patient, soaking him. But that's when he became finally creative, and he realized that if you part the fur, that is important, by the way, parting the fur and then putting the alcohol straight on the skin, A, you're going to increase what you're going to be able to see. B, just by taking that piece of skin, you can move it. And I think we have in the video that we showed, Dr. Boysen is going to show that. That's what we do. We're actually doing a study right now using water. That's going to be very interesting. It's an ongoing study to see if that works just as well. And it seems to as far. We rarely use
it up here. So how am I going to do that? Pull the skin down, a little alcohol here.
Okay, yeah.
Pop the probe on with a marker towards the head. Separate the fur.
Yeah.
And we're just basically going to go straight back until we find that curtain sign.
You see, I'm moving with my left hand, the skin and the site of contact after I've parted the
pleural line and that back.
And I can just
moving
compare
the whole
thorax with
just
only
see that
like
curtain sign again and that pleural line, and we assess
sites
that
of contact
there for the glide sign.
It's
That is how we rapidly rule out.
It's similar to when we do a chest tube in our small animals. Most people will know what we're talking about. You pull the skin to the site you need to start with, separate the fur, and then with my left hand, I can move that pretty much anywhere over that hemithorax.
Sometimes we use gel. Sometimes you're having trouble seeing the heart, for instance. Sometimes we'll apply a little bit of gel because that really helps, but rarely will we use gel.
Great. And one question that also came up a lot was about the people are really into the alcohol and gel thing. I know we asked about it internally, that the spirit or the alcohol doesn't damage these probes, and so it's okay to use them, at least for these probes that we demonstrate. We can't speak for other ones. We don't really know what they're made of.
A lot of that theory comes, if you look back to the literature on what actually affects the probe, you actually have to put it in a jar of alcohol for several days before the probe breaks down. Nobody's going to do that. We're doing
Probably shouldn't do that.
Yeah. And we're doing what, 60 seconds of 5 minutes of contact time maximum per scan, not a week straight of 24 hours continual exposure to that jar of alcohol that the probe's in. So that's where that breakdown theory comes from. And most of the time, like you just said, it's not something to worry about. I've never considered it, I've never thought about it. I do thousands of scans a year, and I've never seen image quality deteriorate because of the use of alcohol. If you want to get around that from a warranty standpoint, what I always tell everybody is put the alcohol, separate the fur, put the alcohol on so you can see the skin. And just before you put the probe on, put a little ultrasound gel on the probe head itself. And then you're not lying when you say, I use ultrasound gel every single time. And be valid.
Nice. That's an insider trick right there. Soren Boysen. I like that. Well, I really want to respect people's time. We're already, over 15 minutes over, and there's still a lot of questions that we weren't able to answer, but we will go ahead and we'll follow up with everyone. We'll have Serge and Soren follow up with everyone through email afterward. Any questions we didn't get to, we're sorry that we didn't have enough time, but there's just so many people participating that it's really hard to get through everything. I really want to appreciate you guys taking the time out of your busy schedule and all our participants. And thank you so much for a really insightful webinar and learning a lot.
Well, thank you so much. It was a huge pleasure to be here. We really appreciate it.
Yes, thank you very much for the invitation. We had a lot of fun. And hopefully we'll see you in person at a conference somewhere or at a lab somewhere, or if not, next time online, or if you're in Calgary, we'll be happy to either take you for a hike in the Rockies or out for a pint.
Thank you so much, Dr. Boysen and Dr. Chalhoub. I'd also like to acknowledge our furry friends, Luna, Serge's dog, and Bourbon, who were the stars of the show. I want to thank you all for joining us. There were quite a few questions about the CE PED credits. We will send you an email in the coming days with several resources, including a PDF copy of today's presentation, a link to the webinar recording, some vet ultrasound video tutorials, and a link to the Vet Show website where you can enter your license number and contact information to receive your CE CPD certificate. You must have attended for 50 minutes in order to receive it. Again, thank you all so much for joining us today. I hope you had as much fun as we did, and we hope to see you all again very soon.
Thank you so much.
Thank you.